Hello again, everybody. So we're going to talk about some select issues in neuro-ophthalmology. We're going to talk about the anatomy of the eye, as well as the visual tract pathway for receiving visual information and transmitting it to the primary visual cortex, as well as different lesions and the different field deficits that they can cause. We're going to talk about the horizontal gaze pathway, which has to do with eye movement, and then we'll talk about some of the gaze palsies, particularly abducens nerve and oculomotor nerve. So this is the anatomy of the eye from the lateral aspect and from the superior aspect on the right. And it's worth remembering that 4 of the major 6 eye muscles that are responsible for movement are innervated by the oculomotor nerve. So it's fair to say that the oculomotor nerve is the primary innervator of the intraocular eye musculature. So the oculomotor nerve innervates the medial rectus, which you can see right here. And the medial rectus turns the eye medially, so towards the midline. The superior rectus is also innervated by the oculomotor nerve. It elevates the eye, moves it superiorly. The inferior rectus, you can see here, coming down around the bottom. And the inferior rectus depresses the eye. The inferior oblique is a muscle that comes along the side here. So that's right here. And it originates from a different point than the rectus muscles. So the inferior oblique actually can elevate the eye, and it can also turn it laterally. So you can see, based on if you were to pull from this point, from here, you would be not only elevating, but you would be pulling the eye in the counterclockwise direction. Okay, so the other 2 muscles, main muscles of the eye, are the lateral rectus and superior oblique. The superior oblique comes in from the same path that the recti muscles come in, except it turns 90 degrees on this trochlea. This trochlea is just an anatomic part of the orbit capsule, and it allows the superior oblique to make this hairpin turn. And the superior oblique is also responsible for turning the eye laterally, but it also depresses the eye. So it's an accessory muscle of depression, contrary to the inferior oblique, which is an accessory muscle of elevation. So this is innervated by the trochlear nerve, and we remember it is that there's the trochlea that changes the direction of the superior oblique, and so it's the trochlear nerve. The lateral rectus is responsible for moving the eye away from the midline, so abducting the eye, abducting, and it's on the lateral side of the eye, not surprisingly. And because this is an abductor muscle, it is fittingly innervated by the abducens nerve. So the abducens nerve's primary responsibility is innervating the lateral rectus, which is what helps your right eye move right and your left eye look to the left. There's one more muscle that's not seen here that's also innervated by the oculomotor nerve, and that would be the levator palpebrae superioris. And that's the muscle that allows the upper eyelid to open. So that's innervated by the oculomotor nerve. So the cranial nerves of relevance that we're going to be talking about in the next few slides are the optic nerve. The optic nerve is a sensory nerve. It relays sensory information from the retina, and it projects that information from the visual field to the contralateral visual cortex. The oculomotor nerve, on the other hand, is a motor nerve, and that innervates those 3 recti muscles, the inferior oblique and the LPS. The trochlear nerve, as mentioned, is a motor nerve as well. It innervates superior oblique. Abducens nerve innervates lateral rectus. And then the vestibulocochlear nerve also plays a role in eye movement, as it provides sensory information from the semicircular canals and allows the eyes to adjust appropriately. We're not going to talk about how the vestibular nerve particularly interacts with eye movement and how it induces changes in the eye movement, but what you should know is that any lesion to the vestibulocochlear nerve can and does cause deficits in defects in eye movement. We talked about vertigo in a different section, and one of the main causes of vertigo is damage to the vestibular nerve, to the vestibular nucleus. Okay, so this is the visual fields, and what I want to stress first is that you have a left and right visual fields, but that does not correspond to what you see with your left eye and what you see with your right eye. If you were to cover up your right eye, everything you see with your left eye that's on the left-hand side, if you were to draw a line down the middle of your field of vision, that's your left visual field for your left eye. And everything you see on the right-hand side of that imaginary line is your right visual field of your left eye. And then the same thing with the right eye. If you were to cover up your left eye, everything you see on the left-hand side from your right eye is the left visual field from your right eye, and everything you see on the right-hand side from your right eye is your right visual field from your right eye. So you have a left visual field from your left eye, a right visual field from your left eye, which is next to the right visual field from your left eye, and the right visual field from your right eye. Now it makes sense that it's the right-hand part of the left eye that sees the left visual field from the left eye. The right-hand side of both eyes view the left visual field. Because of the concave shape of the eye, it makes 90 degrees with if you were to draw a ray from the 90-degree ray from the retina, it would join with the opposite visual field. So here's our left visual field. It makes a 90-degree angle with the retina on the right-hand part of the eye. So the left visual field for both eyes is seen by the right part of the retina. So here's your corresponding to red. Here's your left visual fields, both in the left and right eye, and it's on the right-hand side of the retina that views the left visual field. And the opposite for the right visual field, it's seen on the left part of the eye. Now, all those nerves that see the visual field, they coalesce and form the optic nerve as it leaves the orbital cavity. And that's cranial nerve 1, and that is just your optic nerve. Now, at a point, the information from the left visual field from the left eye and the right visual field from the right eye cross, so that on the left-hand side, on the left side of your brain, you're only carrying visual field information from the right visual fields. And on the right side of your brain, you're only carrying visual field information from the left visual fields. Okay, but before that happens, it's just the optic nerve. When that happens, that's called the optic chiasm, where the information from the left visual field from the left eye and the right visual field from the right eye, those nerves cross. That's the optic chiasm. And once they join up with the continuations of the optic nerve on either side, that's considered the left or right optic tract. The optic tract terminates in the thalamus, and it's called the lateral geniculate nucleus, LGN. And from the lateral geniculate nucleus, there are projections that are sent to the primary visual cortex on the occipital lobe. And the projections are in the temporal lobe and in the parietal lobe. The projections in the temporal lobe are called Meyer's loop, seen here, on both the left and the right side, and the projections in the parietal lobe are Baum's loop. And then it terminates in the primary visual cortex. So on the right part of your primary visual cortex in your occipital lobe, you've got all the information from your left visual fields. And on the left part of your occipital lobe at your primary visual cortex, you've got all the information from your right visual field. So here's your visual fields, and then Meyer's loop and Baum's loop. And also, Meyer's loop projects information from the upper part of the visual field. So on the left side, it contains the upper part of the right visual field, and on the right side, it contains the upper part of the left visual field. Whereas Baum's loop in the parietal lobe contains information about the lower contralateral visual field. So on the left side, it contains information about the lower right visual field, and on the right side, it contains information about the lower left. Okay, so here's your visual field. This is normal. So if you were to look out one eye or the other, you're looking at this, right? You've got red and blue. So on your left eye, you're going to see red in your left visual field and blue in your right visual field. And same with your right eye. You see left in your left visual field out of your right eye and blue in your right visual field out of your right eye. Now this becomes a little easier to understand when we talk about if we have a lesion at a certain point. So let's say we have a lesion to the optic nerve. That's going to cause ipsilateral anopsia. So you lose vision for the entire eye. And that makes sense because if you were to, let's say, cut this nerve right here, you're losing all these nerve fibers. So you're losing all the information from that left or from that right eye. So you would lose all the information from the ipsilateral eye wherever the optic nerve is damaged. And some examples of this include optic neuritis, as we see in multiple sclerosis, an infarct of the ophthalmic artery, optic nerve tumors, and then congenital optic nerve hypoplasia. So this is damage to the optic nerve, and it's obviously going to be ipsilateral. Now, if we have a lesion to the optic chiasm, and usually it's due to pressure on the optic chiasm, it's going to cause bitemporal hemianopsia. Bitemporal meaning it's on the temporal side, and hemianopsia meaning half of the total visual field for that eye. So let's look at this. From the left eye at the optic chiasm, we are crossing information about our left visual field. It's crossing over to the right side, and vice versa for the right eye. From the right optic nerve, we're crossing over information from the right visual field. So if we knock this out here, we're knocking out the right visual field from the right eye and the left visual field from the left eye. And that's what's causing bitemporal hemianopsia. Now, where the optic chiasm is anatomically plays a big role in what causes lesions to the optic chiasm, what causes bitemporal hemianopsia. The optic chiasm sits right next to the pituitary. So any kind of pituitary tumor is going to cause optic chiasm, large pituitary tumors. The optic nerve and optic tract up until the LGN are covered by meninges. So a meningioma can also cause a bitemporal hemianopsia, and then craniopharyngioma as well can also cause bitemporal hemianopsia. And then one more thing, aneurysm of the anterior communicating artery. Remember, part of your anterior circulation that gives rise to your anterior cerebral arteries, that connects both the left and the right side of your circle of Willis. That is right over the optic chiasm as well. So if you have an aneurysm of that anterior communicating artery, that can cause bitemporal hemianopsia. Okay, how about if we have a lesion to the optic tract? Well, this is quite simple. If you have a lesion to the left optic tract, you are going to lose all the information from the right visual fields. because the left optic tract carries all of our information from the right visual field. This is after the chiasm. So it's different from a lesion at the optic nerve where we're containing all of our information from the left eye. At the left optic tract, now we're containing all of our information from the right visual fields. So we keep our right visual field from our left eye, and at the chiasm, the right visual field from the right eye crosses over and joins the optic tract. So at the optic tract on the left side, it's only your right visual fields. So if you have a lesion to the optic tract, you're going to get contralateral homonymous hemianopsia. Contralateral meaning from the opposite side, because you're carrying visual field information from the opposite side. Right visual field for the left side of the brain, left visual field for the right side of the brain. Homonymous because you're losing half of your visual field, or homonymous meaning that it's the same part of your the visual field. So the right visual field in both eyes, or the left visual field in both eyes, and then hemianopsia meaning you're losing half of your total visual field in each eye. So either you're going to lose both of your left visual fields if you have an optic tract lesion on the right side, or you're going to lose both of your right visual fields if you have an optic tract lesion on the left side. Things that can cause this are stroke, particularly MCA or ACA stroke, neoplasm, multiple sclerosis, or head trauma. And usually it'll only cause one side or the other. Okay, so remember that Meyer's loop contains the superior part of the vision from that side. So the Meyer's loop from the left side, on the left side of the brain, contains all of the superior quadrant information, all the superior information from the right visual field on the opposite eye. So if you think about it here, our optic tract on the left side is containing all of our information from the right visual fields. Then it splits into Meyer's and Baum's loop. Meyer's loop contains just the superior half of those visual fields, and Baum's loop contains just the inferior part of those visual fields. So if you have a defect at Meyer's loop, you're going to have contralateral, because it's going to be in the opposite side, homonymous, meaning it's in the same place, superior, because Meyer's loop contains the superior information, quadrantenopsia. And quadrantenopsia just means you lose a quadrant of your vision, because Meyer's loop just contains the superior part of the visual field. And what can cause this are strokes, neoplasm, and damage to the temporal lobe, because remember, the temporal lobe is where Meyer's loop runs. Now, if you have damage to the Baum's loop, remember the Baum's loop contains information from the inferior part of the visual field. So it's kind of like a half optic tract deficit if you have a lesion to Meyer's or Baum's loop. Baum's loop contains the inferior part of the field. So this would be a contralateral homonymous, this should say inferior quadrantenopsia. So if you have a defect to the inferior or to the left Baum's loop, you're going to lose your lower right visual fields from both eyes. Examples of this could be stroke to the PCA, because that is primarily what's innervating the parietal lobe, neoplasm, or damage to the occipital or parietal lobe. Now, if you have damage to your primary visual cortex, that's also going to cause homonymous hemianopsia, because just like damage to the visual tract, you're causing damage to all these neurons that the optic tract contained. So if you have an optic tract lesion, you're going to get homonymous hemianopsia, and if you get a primary visual cortex lesion, you're going to have homonymous hemianopsia, because all of these nerves were once part of this optic tract. The difference, however, is that there's a little part in the middle, a few neurons that you have that make up the middle part of your visual fields, both on the left and on the right, that are fed vascularly by both the left and the right PCA. So if you have a left PCA stroke, meaning a stroke to your right visual fields, you will actually maintain some of the middle part of your right visual fields, because the middle part of the visual fields are fed by both the left and the right PCA. So the right PCA will still be able to keep those neurons alive, and that's called macular sparing. Macular being in the middle part of your visual field. So if you have a PCA stroke to your left visual field, you will lose all of your right visual field except for the little bit in the middle. And then the same on the right. You lose all of your left visual field, but a little part in the middle. And that's different from an optic tract lesion, where you would lose all of your visual field, including the macular part. Okay, we're going to shift gears now to the horizontal gaze pathway. So what we're talking about here is how we move our eyes left and to the right. And how is it that when we move our eyes to the left, both eyes move to the left? When we move our eyes to the right, both eyes move to the right. We have a coordination that goes on there, and that's really important, because if we didn't have that coordination, if we moved our eyes to the right and our right eye moved but our left eye stayed in the same place, we would go cross-eyed and we would have diplopia. So in order to understand how this works, we have to understand how we feed motor input, how we initiate eye movement from the motor cortex. So just like any other muscle of the body, any other skeletal muscle with conscious movement, it is initiated from the frontal lobe. So the frontal lobe, just like the homunculus for the rest of our body, we have frontal eye fields, and those frontal eye fields initiate eye movement. So the frontal eye fields will send projections to what's called the paramedian pontine reticular formation, and of course they're contralateral. So the right frontal eye fields control the left eye, and the left frontal eye fields control the right eye. Now I did include in here input to the PPRF from the vestibular nucleus, just for completion's sake, because the vestibular nerve does provide information on how our eyes should be moving, but we're not talking about that here. So you can disregard the vestibular nuclei for what we're talking about here. So the frontal eye fields feed the PPRF, and the PPRF feed the abducens nucleus, among other nuclei in the brain. So if, let's say, you want to move your eyes to the right, the first thing that is going to happen is that your left frontal eye fields is going to tell your right paramedian pontine reticular formation that we want to start moving our right eye to the right. So, of course, it's got to start from the left because it's contralateral control. It goes down to the PPRF and activates that. Now, the abducens nucleus has two parts. Remember that the abducens moves eyes laterally. So what eye needs to move laterally if we want to move our eyes to the right? It's going to be the right eye, because if we want to look to the right, our right eye has to look to the right, and our left eye has to look to the right. The only difference is the right eye is abducting and the left eye is adducting, because the left eye is going to the midline and the right eye is going away from the midline. So the abducens nucleus has two parts. One, it feeds the lateral rectus directly, and that's going to happen right away. So if we're moving our eyes to the right right lateral rectus gets fed by the abducens nucleus, and that allows the right eye to move right. Now there's this interneuron communication between the abducens nucleus and the oculomotor nucleus that allows, when our right eye moves right, to have our left eye move right as well. And if our right eye is going to move right, that's going to take the lateral rectus. But if our left eye is going to move right, that's going to take the left medial rectus. And so whenever the abducens nucleus is stimulated, not only does it stimulate the abducens nerve, but it also stimulates this MLF, the medial longitudinal fasciculus. And these exist on both sides, obviously, and it stimulates the medial rectus part of the oculomotor nucleus, which allows that medial rectus to contract. So the right abducens nucleus is going to stimulate the left medial rectus to move. So that way we've got our left eye moving to the right via the left medial rectus, and our right eye moving to the right via the right lateral rectus. The right side is using the abducens nerve, The left side, though, is using the oculomotor nerve because the medial rectus is innervated by the oculomotor nerve. But the abducens nerve does have communication to the oculomotor nucleus, and that's through this medial longitudinal fasciculus. And it would be exactly the opposite if you wanted to move your eyes to the left. Now, what do we consider the right MLF and the left MLF? It's going to be where it synapses. So the MLF that synapses at the left oculomotor nucleus is considered the left MLF, this part right here. And the right MLF is going to be this part right here. So the left MLF ultimately is going to be what tells our left medial rectus to move, and the right MLF is going to be what tells our right medial rectus to move. And of course, the medial rectus moves the eyes towards the midline. Of course, this will be a lot easier to understand when we look at deficits. So the medial longitudinous is what makes our eyes move together when we move left or right. Anytime we activate the lateral rectus in one eye, we automatically activate the medial rectus in the other eye. And damage to these fibers would obviously then result in discoordination during horizontal gaze. Because if you were to not have this left MLF, this strand here that goes from right to left, the left MLF, you would stimulate the abducens nucleus and the right eye would look to the right, but you would have no way of getting your left eye to look to the left automatically. And so the right eye would be looking right, but the left eye would be looking straight ahead. And so this would cause discoordinated or disconjugate gaze. So let's look at this. This disorder, if you have this damage to the MLF, it's called intranuclear ophthalmoplegia, either left or right, depending on what INO, or depending on what MLF is being damaged. So if it's the left MLF being damaged, so this MLF here, it's left intranuclear ophthalmoplegia. If it's right MLF being damaged, it's right intranuclear ophthalmoplegia. Okay, so let's say we have left intranuclear ophthalmoplegia. What's that going to look like? Well, first off, let's remember our pathway here. We have our abducens nuclei, and then we have our MLF, our right one here, and our left one here. We're going to say that our left MLF has the lesion. Remember that the MLF goes from abducens to oculomotor. Oculomotor, among other muscles, feeds the medial rectus. And the MLF only goes to the part of the oculomotor nucleus that innervates the medial rectus. So superior, inferior recti, none of that is involved here. This is just horizontal gaze. Okay, so you look straight. That's fine. There's no deficits there. Now let's say you want to look to the left. Well, if you look to the left, what gets activated? The left abducens nerve, because you want to move your eyes to the left. So the left eye needs to move to the left, and if the left eye is moving to the left, it's abducting, so we need to activate the lateral rectus, and that's via the abducens nerve. So the abducens nerve gets activated, and the right MLF gets activated. The MLF going to the right oculomotor nucleus. So I bold-faced it here. And there's no problem there, and so that's going to allow the right eye to activate at the medial rectus. Both eyes look to the left. Left eye uses the abducens nerve, right eye uses the medial rectus. Okay, now let's say, so we'd say here that the left conjugate gaze is intact. Now let's say we want to look to the right. Here's our problem. If we want to look to the right, we have to activate our right abducens nucleus. Now that's fine for our right eye. Our right eye, there's no problem because the MLF has nothing to do with the abducens nerve that goes to the lateral rectus. So the abducens nerve is perfectly intact. The right eye can move to the right, and see it does right here. So the right eye is moving to the right, but at the left MLF right here, we have a problem. And so we can't get our left eye to move to the right as well, to move midline, to move with the medial rectus. And so the left eye does not adduct, adduct. The right eye, though, does abduct because the INO has nothing to do with the direct connection between the ipsilateral abducens nucleus and the ipsilateral lateral rectus. So here's an example. So what we just showed was, what we just showed was left INO, which comes from a left MLF lesion. And so you have no problem with left gaze, but on right gaze, your left eye is not going to adduct because your left MLF helps your eye that's not abducting with your abducens nerve. It helps your other eye that you're not looking in that direction, helps it adduct, adduct. And so your left eye will not look to the right. With right INO, which would be a lesion to the right MLF, you would have a problem with leftward gaze and that your right eye would not adduct, but your left eye would abduct. And then when you look to the right, you're fine because you have no problem with your right abducens nerve or your left MLF. Okay, and then I just denoted it here. The side that is in the green here is using the cranial nerve 3, the oculomotor nerve, medial part, and then part that's in purple here, 6, is using the abducens nerve. Now, in patients who have some diseases, particularly multiple sclerosis, they can get damage to both MLFs at the same time. And so they would have, looking straight, they would have this here normal, but then they would have both a left gaze and a right gaze problem. So they would have both left INO and right INO. Okay, and I just want to add one more time that your MLF, what determines what side it is, because they are decussating. The left MLF is the MLF that terminates at the left oculomotor nucleus, and the right MLF is the MLF that terminates at the right oculomotor nucleus. So it's not where they start, it's where they end. Okay. How about an abducens nerve palsy? So with INO, our abducens nerve was working fine. But now let's say that we had a problem that affected our abducens nerve. Well, then the problem would be in abducting. So normally we look forward, we look left, both eyes go to the left eye is using its abducens nerve, and if we look to the right eye is using its abducens nerve with the lateral rectus. Now, if we have a left abducens nerve palsy, you can imagine that if you don't have your left abducens nerve working properly, the left eye will not be able to look laterally, and that's what we have. If we look to the left, the right eye looks to the left, it's using the oculomotor, but the left eye, needing its abducens nerve, if we have a left abducens nerve palsy, it will not be able to look laterally. However, if we look to the right, it's fine because this requires the right abducens nerve. If we have a right abducens nerve palsy, the left eye will be able to look to the right, it's using oculomotor, and the right eye will not be able to look to the right because that requires the abducens nerve. Looking to the left, you can do that with a right abducens nerve palsy because you're using the left abducens nerve and the right oculomotor nerve. So this would be an abducens nerve palsy. Okay, how about an oculomotor nerve palsy? So remember that the oculomotor nerve is innervates the superior rectus, the medial rectus, the inferior rectus, the inferior oblique, and the levator palpebrae superioris. So the superior rectus moves our eye up, medial rectus moves our eye in towards the midline, inferior rectus moves our eye down, and the inferior oblique is an accessory muscle to move our eye up, and it also can rotate the eye. So if you have a left CN3 palsy, Remember, the oculomotor nucleus innervates the ipsilateral eye. If you have a left CN3 palsy, it's going to affect your left eye. Now, why is our eye looking in this direction? And why is the eyelid covering half of the eye? Okay, let's remember that the oculomotor nerve innervates superior rectus, inferior rectus, and medial rectus. Superior rectus keeps the eye moving in this direction, up. Inferior rectus keeps the eye moving down. Medial rectus allows the eye to move medially. This is the right eye. This is the nose here. And then the LPS keeps our eyelid up. And the inferior oblique also moves our eye up. The trochlear nerve innervates the superior oblique. Superior oblique can move our eye down. And the abducens nerve is the lateral rectus. That moves our eye laterally, in this case to the right. Now, if you have a CN3 palsy, you knock out all of that. So that the only thing that's working is your lateral rectus and your superior oblique. Those are the only muscles that are working in your eye. And so what happens? They basically go in that direction. And your levator palpebrae superioris is also knocked out, so you're going to get ptosis. So your eyelid is going to be down, droopy. So you move laterally and down, and this is called the down and out look. And the down and out look is a CN3 palsy, an ipsilateral CN3 palsy. The other eye will be normal, presuming that you don't have a CN3 palsy on that side either.